Okay, so now we are ready to start. And I want to...
Well, welcome everyone to Budapest and to the Brompton Session. So, as our President Nuria Nawar pointed out, this is an award session, and there will be a discussant after each presentation. So the first presentation is long-term survival outcomes of neoadjuvant chemoradiotherapy compared with surgery and surgery with adjuvant therapy for esophageal squamous cell carcinoma. A prospective randomized phase 3 clinical trial will be presented by Van Woo He.
Okay, thank you for the introduction. Good morning, my colleagues. I'm Dr. He Wenwu from Sichuan Cancer Hospital, Chengdu, China. And I'm a little nervous because of the too many big boss sit here. So it's a great honor to have this opportunity to share with you the funding of our phase 3 randomized clinical trial. Today I will be presenting the long-term survival outcomes compare neoadjuvant chemoradiotherapy followed by surgery versus surgery with adjuvant therapy in patients with ESTS. I have no disclosure. And historically, surgery combined with adjuvant therapy has been the mainstay of treatment for esophageal cancer over the past decade, even if in China. Yeah. And also giving evidence supports the superiority of neoadjuvant chemoradiotherapy, NSRT, followed by surgery. The relative efficacy of NCRT versus surgery with adjuvant therapy remains a matter of clinical debate. So few studies have directly compared the two strategies. And this reminds a lack of prospective data access both short and long-term survival outcomes. So this was a prospective randomized open-label phase 3 clinical trial. A study aims to compare NCRT followed by surgery with surgery followed by AT in patients with local advanced ESTS. Patients with randomized into two groups. The NCRT group received paclitaxel and carboplatin with concurrent radiotherapy followed by surgery. And the AT group received surgery first, then adjuvant therapy or adjuvant chemotherapy or chemoradiotherapy based on the post-operative stage. The post-operative stage, yeah, according to the NCCN version 4, 2017. And our primary endpoint was OS and DFS. Second endpoint include pathologic response, safety, and complications. So from April 2018 to March 2020, 254 patients were screened, and 245 were randomized. After including this without arterial resection, and 224 patients were included in the final analysis, 116 in the NCRT group and 108 in the AT group. Both groups were well balanced in terms of baseline characteristics, include age, gender, tumor location, and clinical stage. The NCRT group had significant more favorable pathological outcomes, including the PCR and the downstaging, as well as this vascular invasion and the nerve invasion compared to the AT group. In the grade 3 or higher AE were slightly more common in the NCRT group, but overall toxicity was manageable in both groups. Post-operative complications were comparable between the two groups. The rate of elastomotic linkage and the 13 days mortality were very low and not statistically different. And so our result is the 5 years OS was 59.4% in the NCRT group and 42% in the AT group. The 5 years DFS was 53.1% versus 56.5% respectively. This was no significant difference in long-term outcomes between the two strategies. The 5 years OS rate for the PCR group was very high. It's 76.5%, significantly higher than the no PCR group, 52.2%, and the AT group, 62%. The non-RAG tests show a significant difference between PCR and the no PCR groups. And this was no significant difference between AT and the no PCR groups. So according to our data, so we have achieved PCR is association with a clear survival benefit. And for patients who don't achieve PCR, maybe AT offers compatible survival outcomes. And our DFS, the 5 years DFS rate was 67.6% for the PCR compared to 46.8% for no PCR and 56.5% for AT group. The difference between PCR and no PCR was statistically significant. No significant difference was observed between AT and the no PCR group. According to this data, so we have PCR have also association with a significant improvement in DFS, further supporting its role as a prognostic indicator. So conclusion, we have NCRT followed by surgery, and the surgery with AT resulted in comparable long-term overall survival in patients with locally advanced ESCC. And NCRT provides significant pathological advantages, include higher PCR rate, and higher PCR rate, PCR group have a higher OS and DFS, and more frequent tumor downstaging. The safety profile of the two groups were similar, with no significant difference in post-operative complications or perioperative mortality. Patients with achieved PCR have a markedly higher 5 years survival rate compared to this no PCR patients. This finding emphasizes the need to identify patients likely to benefit from NCRT. We try to find the biomarkers. Realized that for no responders, upfront surgery with adjuvant therapy remained a valuable treatment strategy. Okay, thank you for your attention. If you have any questions, you can email me.
Thank you, Dr. He, for this presentation. So the presentations are for 8 minutes, and the discussion is Dr. DiGiorno from Marseille for 4 minutes discussion and by the discussant, and then we will have 3 minutes discussion by the audience.
Mr. President, Mr. Chairman, dear colleagues, members and guests. I would like to express my gratitude to the organizing committee for the opportunity to discuss this study from our distinguished colleagues from the Sichuan Cancer Center in China. The author present a high-quality randomized trial comparing two treatment strategies for esophageal squamous cell carcinoma. On the one hand, neoadjuvant chemoradiotherapy, similar to the CROSS protocol, widely adopted in most Western countries. On the other hand, primary surgery followed by adjuvant therapy, a traditional approach now less commonly used. Only two previous trials have directly compared these two strategies with no definitive conclusions. The present study shows that while the neoadjuvant arm achieved better tumor downstaging, a higher complete pathological response, long-term survival was surprisingly similar between groups. Three key issues should be considered when interpreting these results. First, regarding study design and patient exclusion. 6 patients were excluded from the neoadjuvant arm and 15 from the adjuvant arm. This post-randomization exclusion, not clearly justified, shifts the analysis from intention to treat to a per-protocol analysis, introducing potential attrition bias and increasing the risk of type 2 error. Secondly, regarding baseline imbalances, the adjuvant group included more N0 patients, which may reflect a prognostic advantage and may impact overall survival comparisons. Thirdly, regarding treatment heterogeneity, adjuvant therapy was not standardized. Some patients received chemotherapy alone, other chemoradiotherapy, make it difficult to draw firm conclusion. I would like to ask you just one question, one that I believe is central to the current evolution of treatment strategies. In light of the results of the CheckMate 577 published in New England Journal of Medicine in 2021, which introduced adjuvant nivolumab for patients with residual disease after neoadjuvant chemoradiotherapy, the so-called quadrimodal approach is becoming a new standard of care. In this evolving context, what is the rationale for continuing to support primary surgery followed by adjuvant therapy?
Okay, thank you for your questions. You gave a lot of comment about our study. And the question is, because stand here is not very clear about
I would like to remind you my last question. Do you believe that adjuvant therapy is better to provide nivolumab in adjuvant after neoadjuvant preoperative treatment?
I believe because we found our group try to find the biomarker, and our plastic found the new chemoradiotherapy after the new chemotherapy after surgery. We found the PD-L1 expression higher than the before. So we also have another clinical trial. It's about the follow the new adjuvant chemotherapy, give the chemoimmunotherapy, have 20% PCR higher than directly surgery. So I believe the outcomes about the CheckMate 577. Yeah. So we try to find the biomarker. In this study, we try to find the biomarker to split which person can get more benefit from the new NCRT. Okay. Yeah. So yeah. Okay. Thank you very much.
Thank you.
Thank you for your answer. And the paper is now open for discussion. Are there any comments from the floor? Please.
Okay, thank you.
Please
Thanks,
state
Professor.
your name and your country, and then
Thank you.
city and country.
I'm Dr. Leng. I'm one of the team's member of this clinical trial. So thanks for the professor's question. So I will make some supplementary comments for this clinical trial. So this is a randomized clinical trial, but it's an IIT clinical trial. It's different like a GCP trial. So there were some, some problems, some questions in it, of course, some inclusion, exclusion criteria. But finally, after this studies analysis, we will do the ITT analysis and some PSM analysis. After that, we can show some final results about these treatment strategies. But in fact, we can say for this clinical trial, adjuvant treatment is not the standard right now because we have a lot of clinical trials, evidence-based trials showed neoadjuvant treatment combined surgery or the perioperative treatment is the standard of care for the esophageal cancer treatment. But in fact, in East Asia, especially in China, more than 90% are squamous cell carcinoma. So during our daily practice and our clinical trials, we can see maybe only 30% or nearly 40% patients are sensitive to the neoadjuvant treatment, no matter you use NCRT or immunotherapy, but some of the patients are not sensitive. So I think in the daily practice and this clinical trial, it showed some patients will benefit from the upfront surgery combined adjuvant treatment. But adjuvant treatment is different kind of modalities. Chemo combined immuno, or some patients, we add some radiotherapy, maybe benefit for the patients. That's my comments. Thank you.
Thank you, Dr. I think for time concerns, we have to finish the discussion. Thank you for your nice presentation.
Thank you. Thank you.
Thank you very much. The next presentation is going to be lymph node involvement in radiological predictors of invasiveness in adenocarcinoma, presenting as pure ground glass opacities, the Gordon study by Dr. Catalini Gureni.
Good morning. I would like to thank the committee for giving me the opportunity to present our work today. I have no disclosure to declare. Pure ground glass opacities are increasingly identified on a CT scan, especially in case of lung cancer screening. They are often associated with early-stage lung cancer, and they are typically indolent. They have predominant lipidic growth pattern and a favorable prognosis, especially in case of minimally invasive adenocarcinomas and adenocarcinomas in situ. However, the surgical treatment consists in anatomical resection with systematic hilar and mediastinal lymphadenectomy that could come with prolonged operative time, possible post-operative complications, and prolonged hospitalization. There are several works that show that in case of pure ground glass opacities, there is a small risk of lymph node involvement. So we ask ourselves, is systematic lymphadenectomy always necessary in case of radiological pure GGOs? And is it possible to identify which pure ground glass are truly invasive based on CT findings? And can we use this to guide our surgical decision, especially whether to omit lymphadenectomy? From here started the idea of the Gordon study. This is a retrospective multi-center study that included 6 Italian high-volume thoracic surgery centers, Rome, Milan, Padova, Siena, and Naples. And we included all patients that between 2013 and 2024 underwent surgical resection and lymphadenectomy for adenocarcinomas presenting as pure ground glass opacities. We decided to exclude PGGOs bigger than 4 centimeters, patients with previous solid lung tumor, and patients underwent inadequate lymphadenectomy or inadequate preoperative and follow-up radiological evaluation. Here you can see all the variables that we investigated. Of course, qualitative CES CT analysis, quantitative CES CT analysis, histological diagnosis, and of course the follow-up at 1, 3, and 5 years. The first goal was to evaluate the incidence of lymph node involvement in surgically resect pure ground glass opacity. Our secondary goal was to assess the lymph node recurrence and to identify eventually radiological predictors of histological invasiveness. For what regards the radiological predictors, we investigated qualitative parameters such as the margins, the bubble-like lucency, the pleural attack, and of course the bronchus sign, the vascular supply, and of course quantitative analysis such as the maximum diameter of the lesion and also the density of the lesion. We evaluated in an enhanced and anterior phases with a long window, placing the region of interest, the ROI, on the most representative part of the GGOs, avoiding vessel as bronchi. The same ROI was then copied onto the arterial phase to ensure consistency. Of course, we have done the same thing for the parenchyma to calculate these two variables, the differentiated value and the relative attenuation, that are the difference in the ratio in density between the nodule and the surrounding healthy parenchyma. From 474 patients, we included 400 patients that were divided into invasive adenocarcinomas and non-invasive adenocarcinomas, including minimally invasive adenocarcinomas and adenocarcinomas in situ. Here we can see the first results. As you can see, the majority of the patients underwent lobectomy, maybe an overtreatment in this case of indolent lesions. And you can see that the prevalent growth pattern was acinar in case of invasive adenocarcinomas and lipidic in case of non-invasive adenocarcinomas. But here you can see the most striking results. The 100% of patients didn't show any lymph node involvement, and that the lymph node disease-free survival at 1, 3, and 5 years was 100%. Here you can see the CT findings. Here you can see that the qualitative analysis, the speculating margins, the pleural attack, and the bronchus signs were predictive factors of invasiveness. And a higher maximum diameter, a higher density in an enhanced CT scan and post-contrast CT scan, and also the different CT value and the relative attenuation were predictive factors of invasiveness. Here you have 4 variables that you can evaluate only just with an enhanced CT scan. So we decided to take these 4 variables and to do single rock analysis to individuate the threshold above all we can predict the invasiveness. Here you can see the values, but we were not very satisfied with the sensitivity and specificity of these results. So we decided to do a combined rock curve with these 4 variables. As you can see, the maximum diameter and the GGO and enhanced CT attenuation were confirmed independent predictors of invasiveness with a specificity of 82%, a sensitivity of 76%, and an area under the curve of 87%. The different CT value and the relative attenuation were complementary rather than independent predictors of invasiveness. Which are the key findings of this work? Of course, as you can see, despite their indolent imaging appearance, a large majority of pure GGOs were invasive, the 86%. Despite this, no lymph node involvement was identified, suggesting their extremely low nodal metastatic potential. And we saw also an excellent long-term disease-free survival, the 100% at 5 years. Radiological predictors such as the radiological diameter higher than 18 millimeters, a basal CT attenuation higher than minus 390 Hounsfield units, pleural tab, bronchus sign, higher arterial phase CT attenuation are predictors of the invasiveness. And these CT-based measures are simple and reproducible. So which are the clinical implications of these findings? Of course, we can guide a precision resection strategy for this kind of pure GGOs. And also, we can guide our follow-up and surveillance. We can decide when to resect the nodules during their follow-up, their CT follow-up. And of course, we can manage the multiple GGOs. As you can see, we can find different GGO in the same patient, but they are very different. So we can decide which to resect before. In conclusion, pure GGOs, even when invasive, carry minimal risk of lymph node involvement or recurrence. These findings support a paradigm shift toward de-escalation of lymphadenectomy in carefully selected patients with pure ground glass opacity. Our findings highlight the clinical value of simple or rapid CT measurement, particularly the lesion size and attenuation, which provide a strong predictive value for histological invasiveness and may guide a more individualized conservative surgical approach. And finally, in the context of lung cancer screening, the integration of radiological predictors, such as the lesion size and attenuation into clinical workflow, may allow for more personalized surgical strategies. Thank you very much.
We'd like to invite Dr. Kelvin Lau from the Barnes Thorax Center to discuss this presentation.
So I have a couple of slides.
Can we have the slides
Okay,
of the discussion, please? Thank you.
Okay, so I have to congratulate Dr. Catelli and her team for doing this study, because in terms of ground glass opacity, the vast majority of evidence comes from Asia or in the diaspora Asian population in the US, for example, and there is a big lack of outcomes for patients in Europe. So this is to be congratulated. They looked at the outcomes for resected pure GGOs up to 4 centimeter. That's a little bit bigger than most studies that usually use as a cutoff of 3 centimeter, but might explain some of the outcomes. So they have a higher lobectomy rate. This may be because the lesions are selected may be bigger. It may be because this was done over an 11-year period before the evidence for segmentectomy. But interestingly, different from the Asian studies, even within the resected population, there's a relatively high invasive adenocarcinoma finding. There's generally a broad, but for the patients who are selected, this may reflect that they have a very good selection criteria to select out the invasive ones to operate on. But to interpret the rest of the study, we have to remember this is not a study of ground glass lesions in general. This is a study of resected ground glass lesions that are proven to be cancer, and then to discriminate between the invasive and non-invasive. The primary outcome is to look at the lymph node involvement to make it to try to conclude that you don't need to do lymph node studies, lymphadenectomy. So they have a lymph node recurrence rate of 1/76 months, and actually 100% at 5 years of lymph node disease-free survival. But it's interesting, they conclude you don't need to do lymph node dissection, but their study excluded patients who have an inadequate lymphadenectomy. So if you want to show that you don't need to do lymphadenectomy, you should also take this opportunity and show the results of your 70-odd patients excluded because they haven't had lymphadenectomy, to show that actually your conclusion is supported by your own evidence. The secondary outcome is to look at the invasive predictor of invasive cancer on the CT. And they used the ROC, the ROC curve, to look at 4 variables: size, attenuation, different CT value, and relative attenuation. There are 2 problems here. One is this population is the resected group. So you built in your selection bias for the resected group. Therefore, when you see size and attenuation in there, it's hardly surprising because you probably selected those patients for surgery because of the size and the density of the lesion. The second problem is when you have 2 variables that move together, so difference in CT attenuation and relative attenuation. One is the difference between normal lung and the ground glass. One is the ratio. They move together. So the higher the difference, the higher the ratio, the relative. When you have 2 variables that are so collinear, they will drop off your study because they both have huge standard deviations. So it's hardly surprising. It's not to say that they are irrelevant. It's just that you should try to do one after another separately rather than together. So In summary, and the other thing is, of course, those are the variables we know about, but now there is a lot of machine learning studies out there, and some of the studies looking at pure GGOs have already got predictors and models that have the AUC of 0.9. So I think you have a very rich, very European relevant database. You should be running machine learning data on there to include all those variables that you cannot see with your eyes. So in summary, very, very good European data, multi-center, very strong evidence. It's interesting to see that invasive malignancy is very common. The confirmed lymph node metastases are rare, but we need to see those in the excluded patients. Beware of collinearity when you're trying to eliminate factors for your model. And the other question is, does this CT information apply to your very, very discriminated to decide on surgery? Because these are post-surgery patients, so whether they're applicable to the general ground glass lesion cohort to decide on surgery is another question. Thank you.
Thank you very much for the questions, very interesting. First of all, I wanted to say that, of course, we excluded the inadequate lymphadenectomy, but we have evaluated also these patients. They are not in the study. There were, I think, 35 patients with no lymphadenectomy at all. I looked at of course, their possibility to have a recurrence, and we didn't see any recurrence also in these kind of patients. But we are doing another study with these kind of patients. So, but they are a small sample, so we decided to exclude now for this type of study. After that, yes, for what regards the findings, the radiological findings. Yes, I know that now there are a lot of predictors and artificial intelligence that can done this for us, but the high relevance of this study is that we can, all of us can detect these findings in 5 minutes seeing the CT scan. And this for the routine is a big help for everyone because it's very easy. It's something that we are used to do, but we don't have cut-off to do so. Every time that we saw a CT scan, we can see that there is a difference between the parenchyma. We can see that we have GGOs that are more dense, pardon me for this adjective, but there are GGOs and GGOs. They are not all the same. So with these parameters, we can guide our decision. Also, our surgeon, that we are not
Thank
radiologists.
you, Chiara. Thank you. We have time for just one question. I think, Frank, you are first, so you get one question.
So, Frank Detterbeck, Yale University. I have just a comment. I think that we should, personally, I think we should not be resecting pure GGOs, period. I also think that whether the resected pure GGO is invasive or not invasive doesn't matter. The studies that have shown that AIS-MIA does better than invasive cancer, those studies have all included nodules, some of which were completely solid, but not just pure ground glass. Those studies that have looked at only pure ground glass tumors show that you have the same survival, whether it's an invasive cancer or non-invasive cancer. It's about 100%. And I just don't think those patients should be resected at all. To me, the marker is, does it change over time? Does it develop a solid component, et cetera? Not just, it's there.
Thank you. Any comment? Just very
Yeah,
quickly.
I think this is a great comment, but I think that the natural history of the GGOs could be to become partially GGOs, partially solid. So maybe this
Thank
is
you
the
very
problem.
much.
Okay, then we move to the next paper. Comparison of 40% glucose solution and autologous blood patch pleurodesis for postoperative air leak after lung resections, prospective randomized study by Pietro Skrovac from Poznan.
Hello, everyone. There is my great pleasure to present to you the results of my study focused on non-surgical treatment on post-operative air leak. I have no conflict of interest to declare. Prolonged or persistent air leak is one of the most common complications in thoracic surgery, usually defined as a continuous air loss from the lung parenchyma beyond the 5th day after surgery, and is usually reported from 5 to even 25% of all lung resection with so well-established risk factors such as pleural adhesions or operation performed in patients with incomplete interlobar fissure, patients with several pulmonary diseases like COPD or asthma, and patients with low preoperative FeV1. Persistent, so POL, prolonged postoperative air leak, is usually connected with prolonged, requires the prolonged chest drainage causing patients pain and discomfort as well as delayed recovery. And patients with underlying pulmonary disease, in that cases, the POL could aggravate the clinical course causing further complications such as ARDS, emphysema, or even increased mortality. So the effective management of POL usually has a potential to reduce morbidity, improve patients' quality of life, and lower hospitalization costs. So the current gap in knowledge. We have the both surgical and no-surgical ways of treatment these complications. However, the treatment methods has limited evidences, mainly based on heterogeneous studies and mainly institutional protocols, which is followed by lack of standardized recommendations for the treatment. And the aim of our study was the comparison of efficiency of installation of 40 glucose solution and the autologous blood patch pleural disease, ABPP, in the treatment of PAL following anatomical lung resections. So we designed this prospective single-center open-label randomized controlled trial with 1-to-1 allocation ratio, which was approved by our university bioethics committee and was also registered on clinicaltrials.gov. And patients were enrolled between November 2023 and December 2024. We included patients in the age of 18 or older, patients after anatomical lung resections, segmentectomy, lobectomy, or bilobectomy, and patients who were able to give the informal consent. We excluded patients after other surgeries such as lung transplantations, sleeve resections, and veg resections, patients in whom the peripheral blood volume was not able to collect, so it was below 120 milliliters, which was required, patients with active infection or sepsis with mental health impairments, and patients who failed perform free ABPP or 40 glucose solution installations if was required because of no consent or other surgical reasons, for example. So we assessed initially for eligibility these 178 patients, which finally analyzed 47 patients in the glucose solution group, so the study group, and 63 patients in the ABPP group. During the procedure, we performed pleurodesis earlier on post-operative day 3, starting from installation of 20 milliliters of lignocaine and then 120 milliliters of both sealants in 48 hours intervals with maximum 3 administrations. Patients remained supine for 2 hours after the procedure. We used the digital monitoring system, and also we measured the blood glucose 30 minutes prior procedure and 30 minutes after procedure for both sealants. Here's how we position our patient with this characteristic drain suspended over the strap in order to prevent from backflow. The primary endpoint was the resolution of PAL after a maximum of 3 administrations, and the resolution was defined as a sustained air leak below 20 milliliters per minute for at least 8 hours using the drainage pressure -8 HO2, successful drain removal, no pneumothorax on a controlled chest radiograph, and also the discharge home. The secondary endpoints were the drainage duration, length of hospital stay, post-pleurodesis chest pain, residual pleural space, and additional surgical intervention, mainly the redo surgery and re-drainage. Residual airspace was defined as a layer of air in the apex of pleural cavity more than 30 millimeters. And the results. Administration of 40 glucose solution was significantly more effective in resolving POL. It was 95% versus 82%. Also, patients in the 40 glucose group had a significantly shorter postoperative hospital stay, the median 7 days versus 9 days. Patients after ABPP also more often required prolonged pleural drainage. 2 patients in the whole group required reduced surgery, 1 in ABPP group and 1 in the glucose group, and 11 required continued drainage. Of these, 5 required home drainage with Heimlich valve drainage, 3 in the ADPP group and 2 in the 40 glucose group. However, in all patients with the Heimlich valve drainage, it was removed after 30 days. Here, we've got the Kaplan-Meier curve showing the results from operation to discharge home, showing the more stepped decline in the glucose group, as well as the more dynamic decrease in the number of risk patients between the 4th and the 10th day after the operation. Secondary outcomes. Post-pleurodesis chest pain required non-opioids was more frequent in the 40 glucose solution group. However, it was not statistically significant. Also, we observed the rows of blood glucose by a median of 71 milligrams per deciliter 30 minutes after administration. However, it did not require insulin intervention. However, we also did not require strict fasting from our patients. No major infections according to all groups, both groups, and the incidence of RAS and reoperation rates were comparable among the groups. So to conclude, intrapleural administration of 40 glucose solution is a safe, simple, and more effective alternative to ABPP for managing POL. It shortens hospital stay and reduces the need for prolonged drainage, and is a promising candidate for standard conservative treatment of POL, as well as an element of ERAS protocol. Thank you very much for your time.
Now it's my pleasure to invite Dr. Jessica Donington to make the discussion.
Thank you. Thank you very much for the invitation, and thank you, Dr. Skripczak, for this trial. First, congratulations. To complete a prospective randomized trial on over 100 patients in a single institution in a single year is incredibly impressive. The organization and real effort that takes is to be commended. I think this is an important trial for several reasons. Air leaks are not going away, and as we do more segmental resections with more parenchymal dissection, I think they are going to continue to be a problem. This is also really intensified by the fact that our hospital stays are getting shorter and shorter and shorter. And I think it was Dr. Cerfolio who taught me that actually a prolonged air leak is considered anything that keeps a patient in the hospital. So in the case of his surgery, that might be a leak that goes on for 2 hours. For mine, I would say anyone who's leaking at 1 or 2 days is already causing a problem and dissatisfaction with our patients and needs to be addressed. I think there are several strengths to your trial. One, I think getting something that's off the shelf to treat these is important. Patients don't like having 120 cc's of blood drained 2 or 3 days in a row. So I think this is a nice alternative. I also like the fact that you started early and did not wait for 5 days. That being said, I have several questions. As a randomized trial, you didn't have any stratification factors, and yet we know that there are many patient-related risk factors for prolonged air leak that probably need to be accounted for. So extent of COPD, extent of resection, upper versus lower lobes. Did any of that come into play here? Because I think they weren't even between your groups.
So as I mentioned in the manuscript, we didn't perform any stratification in this particular randomization, so it was just one-to-one allocation. This group, 100 patients, seems to be too small to perform the proper analysis of, for example, the regression that will show the influence of such factors on for example, success of pleural disease or the hospital stay. But it's all really important factors that could also impact this actually quite simple analysis, but we plan to continue this analysis to perform more of this pleural disease and then analyze these factors that could impact also the results. So,
Also, I didn't see a power analysis. It was just 100, how did you decide 147 patients?
Yes, we performed the power analysis. It should be about more, so 150 in both groups to distinguish this 10%, for example, difference in both between the groups. So, yes, it's not the probably final result of this analysis.
Also, it wasn't clear to me, did everyone in both groups all get 3 installations of the sclerosis, or were there patients who required less?
Yes, I should clear it because it was not clear in my presentation. Not all these patients required the 3 installations. It was 3 installations, maximum 3 installations, if it was required. Sometimes the glucose has especially glucose, has a really good outcome after even 1 installation, and it is enough. We remove the drainage, observe patient for 1 more day, perform the chest CT, and that was the final. However, if the early persists, and if patient required 1, 2, and 3rd, and if in the situation where it cannot be done because of reduced surgery, patient's bad condition or anything, we excluded it from the analysis. Okay. So not everyone.
And my final question, it seemed like very few leaks healed before 6 days, and pretty much your analysis or patients were sent home around 14 days. Did your trial need a control arm with no intervention?
Really hard to hear.
Oh, sorry. Most people can hear me so well, I'm loud. But your leaks still healed at about a median of 7 to 8, 9 days after surgery. Would it have been strengthened by a real control arm of no intervention? Because a large percentage may have just healed with time alone.
Yes, it's also one of the problems. I didn't invent the earlier pleural disease. It was, I took it from 2 other studies by Dr. Frechette and Dr. Langlands-Durski. It was their idea to make this intervention earlier. And it's always the question if the patient was leave itself or discharge home with for example, home drainage, will give the same result. And yes, I cannot answer clearly for that question because I have the same doubts now.
Well, congratulations. I'm excited to try this at home at my own institution.
Thank you very much.
Please,
Bo
state
Holbæk.
your name and your country.
Bo Holbæk, Copenhagen, Denmark. I think this is very interesting. In our institution, we usually rotate patients for 2 hours to make sure that the blood is in contact with the rest of the lung, especially on the forepart. And I usually put patients in Trendelenborg, so if there is an air leak on the apical part, that the lung is in connection with the blood, because often the patients will be lying with an elevated head. So did you make them rotate during your period?
Yes, thank you for that question. I know this way of performing the pleural disease. We stopped with rotating our patients just to minimize the possible tiny things that could impact our analysis. We just tell them to lie supine. In some studies, patients are advised to rotate every 15 minutes. I'm from Wielkopolska region, so really strict to the point. Guys who also sometimes, our patients want to be super performers and want to rotate even 5 minutes to help his doctor and for the doctor to be glad. So we stopped from rotating our patients. Yes, because of possible impact also and hard to quantification of this matter.
I'm sorry, there is no possibility for more questions. I invite you to go to the author after the discussion. Thank you.
Thank you very much.
So now we are going to the fourth presentation. It's float versus cross of adenocarcinoma of esophagus and GE junction. It's a German study, population-based. It will be presented by Dr. Tahir Abdallah from Germany.
Good morning, distinguished colleagues, members of the ESTS, members of the jury. Thank you very much for the kind introduction. I am very honored to present our data at the Brompton Session today. Today I will present our population-based real-world validation of the ESOPEC trial. I have nothing to disclose. In the last decades, neoadjuvant therapy has become the mainstay of treatment in locally advanced adenocarcinoma of the esophagus. Two main landmark studies have set the current practice. On the right side, we see the cross trial. This study was published by the Dutch group in 2007, and they established neoadjuvant radiochemotherapy and operation and showed a median overall survival of 49 months. On the left side, we see the flood trial, which was published in 2018. It was also a multi-centric study which established FLOT. It was FLOT, Operation FLOT. However, there was till now no head-to-head comparison between both studies. This year, the ESOPEC trial was published. We can see here this changed, however, how we see the current multimodal therapy. Here, they showed us that FLOT was superior to CROSS, with FLOT having a median overall survival of 66 months compared to CROSS with 45 months. However, the question remains, how do these outcomes perform in everyday clinical practice outside of controlled clinical trials? Therefore, we performed this externally validation of the ESOPEC trial. We asked for the cooperation of the Arbeitsgemeinschaft Deutsche Tumorzentren. This is a non-profit institution. They collect data from clinical registries, and they analyze it and present it every 2 years in the German Cancer Congress in order to improve oncological outcomes in Germany. We tried to simulate the ESOPEC trial. Therefore, we included all patients with esophageal adenocarcinoma who underwent total esophagectomy in curative intent, who had either FLOT or CROSS. We excluded all patients with CM1, all patients who had CT1, CN0. Any patient who had immunotherapy was also excluded. Patients who had no survival data or had no TNM classification. To simulate the ESOPEC trial, we conducted a propensity score matching. Here we can see age, sex, T and N, and localization, clinical staging before operation. And then we tried to analyze the data, and we took a look to tumor response, survival analysis, and then we took a look also at the patterns of recurrence. This is an observation of our data set before matching. This is unmatched data. Here we can see a very important observation. For example, in the year 2016 and 17, CROSS was the most common regime used in Germany. In 2018 and 19, the FLOT4 trial was published. And since then, a shift was shown to in favor of FLOT, showing more acceptance in FLOT in Germany regarding multimodal therapy of adenocarcinoma. This is the data here, the patient characteristics. On the left side, we can see patients before matching. They were 823 patients. We can see that the CROSS patients were before matching older. They had larger tumors, although not statistically significant, more lymph node metastases with more proximal tumors, more difficult to treat tumors. We matched the cohort, and now we see that we have a homogeneous population, 260 patients in each arm with a similar age and clinical stages. this is the post-operative results. Here we can see that in the cross arms, there were smaller tumors, there was less lymph nodes, there was similar R0 resection rates, and there was higher pathological complete response, down 15% versus 12, although also statistically not significant, but it was higher in the cross group. However, this did not translate into a better overall survival. We can see here that the float arm had a median overall survival of 36 months compared to 25.5 months in the cross arm. And we asked ourselves, why? And therefore, we performed the first analysis was patterns of recurrence. We can see here that the local recurrence rate was similar between both groups, but the distant metastases were different. In the cross group, there were more patients with distant metastases in follow-up compared to float. This means that cross has a really good local control, but the distant control is not well done. Then we took a look at the 90 days mortality. And here we can see that in the cross arm, there was 11% 90-day mortality compared to 6% in the float arm. And then, so we validated now the ESOPEC trial, but now we ask ourselves, is there maybe a subgroup that probably has a benefit from both regimes? And yes, we found one. Or we think we found one. There, in clinically nodal positive, we can see that float is way better than cross. However, in clinically nodal negative patients, there is not really a survival benefit, or at least it's not inferior. This data should be cautiously seen because we have only here 100 patients. So we are underpowered to make a strong conclusion, but it shows us maybe the way for future studies. In conclusion, we externally validated the ESOPEC trial. We showed that float is associated with longer survival than cross, lower 90 days mortality rates, lower incidence of metachronous metastasis, and regarding clinically nodal negative disease, we should think if cross is non-inferior. I would like to thank my co-authors, colleagues, as well as the German Cancer Registry Group for their collaboration. I look forward to your questions and the discussion led by Professor Luketic. Thank you very much.
The discussant is Professor Luketic from Pittsburgh.
Good morning. I'd like to first thank the organizers of the ESTS 2025 for giving me the opportunity to comment on this important contribution to the management of patients with resectable esophageal cancer. I would also like to congratulate Dr. Abdullah and colleagues for their external validation study of the ESOPEC trial. As noted in their discussion in the paper, the ESOPEC trial has now established FLOT as superior to chemoradiation for resectable adenocarcinoma. The question for clinicians is, will the ESOPEC data lead to an immediate adoption of FLOT over chemo-RT, which is now recommended in ESMO guidelines as the primary regimen for locally advanced esophageal adenocarcinoma. Historically, the authors point out that changes in therapy do not always follow even randomized controlled trials for a variety of reasons. Importantly, the authors discussed the reasons for this failure to adopt new guidelines, and their goal was to attempt to validate the results of the ESOPEC trial, which they nicely did, showing that FLOT was superior to the cross for resectable adenocarcinoma. And I think this is an important step in adoption of ESOPEC. So my first question is regarding additional therapies like immunotherapy in this setting. Since the Checkmate 577 established that immunotherapy after chemo-RT improved survival compared to cross plus placebo, do you think that the results of the recent Matterhorn trial will have similar delays in adoption of immuno to FLOT? If so, do you have any plans to validate the Matterhorn findings while not fully released in, say, a real-world setting, as you have done very nicely with the ESOPEC data? Or do you think there might be a more rapid adoption of FLOT plus immunotherapy? My second question is the 90-day mortality that you noted and discussed in your trial was 6 and 11% respectively, a bit higher in the chemo-RT. This is approximately double the ESOPEC trial, and I wondered if you had any comments about the surgical approaches in the different centers. Did that differ? Was there possibly a learning curve of robotic or minimally invasive approaches in either arm? I could not ascertain that from reading the trial. And then another comment, and maybe you can enlighten me on your thoughts about the lower CR rate in the chemo-RT arm in both studies. I think we're used to seeing cross-treated patients with a CR rate over 20%. So seeing it as low as 10% and even a bit higher in the flat arm was a bit surprising to me, although the nodal CR rate was quite good in both arms, 50% or better. So if you had any comments about that, do you think there might have been differences in the technique of delivery of radiation or the success of getting all of the treatments in? Again, my congratulations to you and your group on completing this trial, and we're hopeful that this will lead to a more rapid adoption of randomized clinical data into real-time delivery. Thank you.
Thank you.
Thank you, Professor Lukitic, for these important questions. I would like to start to address the first question. According to our data and also the ESOPIC trial, we see that the strength of the cross regime lies in radiotherapy, which leads to a more local disease control. That means that there is a weak chemotherapeutic component in the cross regime, which lead to distant metastasis, as I showed, and follow-up. This could definitely be tackled down with Checkmate trial, which showed that adding nivolumab to a neoadjuvant chemotherapy improves disease-free survival. We still don't have overall survival data, but it should translate into better overall survival data. So I think, yes, it could improve this regime. However, also, this year was published the data of the Dante trial. It's the same as this one, FLOT, but they also added immunotherapy. And they showed that, for example, in our trial, we have a PCR rate from 12%. In the ESOPIC trial, it was a bit higher, it was by 15%, but the Dante trial led to a PCR rate of above 25-26%. So this will also translate to a better overall survival, as the previous colleagues showed. And so the next level of studies would be no more chemotherapeutic regimes against each other, but would also include immunotherapies. I think this answer will be resolved in 10 years, maybe. And regarding the second question, yes, you're right. The 90 days mortality rate was definitely way higher, or double as much as published in the ESOPIC trial. But the ESOPIC trial was conducted at excellent centers. For example, the last author of the ESOPIC trial is Professor Grimminger in Mainz, and he performs over 150 patients a year, and he is the last author because he included so much patients in this trial. So I believe, yes, it has a selection bias, or it's not selection bias, but it is a randomized clinical trial. It is conducted at excellent centers, and this is actually what shows the importance of our data, because they are real life data that shows us also what happens in a hospital that performs operations at 10% with 10 patients a year. And regarding the last question with pathological complete response, pathological complete response rates for over 20%, it's something what we usually see when we combine adenocarcinomas and squamous cell carcinomas. But if we take a look at also only adenocarcinomas, the PCR rates is always about between 10 and 15%, like an ESOPIC trial, like a NeoIGesis trial. So definitely immunotherapy will help. As I said, the Dante trial showed a PCR rate of almost 25%. This will definitely improve the survival rates. But the question is, can everyone in the world afford immunotherapy? That's something that we will also see, because right now immunotherapy is really expensive.
Thank you, Dr. Abdullah. I think in concern of time, we need to stop the discussion. Thank you for the presentation.
The next paper is going to be longer explantation time during lung procurement has no impact on primary graft dysfunction, presented by Dr. Provost.
Honorable Chair, dear colleagues, I would like to thank the organizing committee for the opportunity of this presentation. With regards to this presentation, I have no personal disclosures. Primary graft dysfunction is the most important cause of early morbidity and mortality after lung transplantation. Clinically, it represents acute lung injury within the first 72 hours after lung transplantation, and it is defined by pulmonary edema on chest X-ray and hypoxemia. PGD grade 3 is the most severe form, and it is linked with worse outcome. Now, in my own experience, over assisting over 50 lung transplantations, I have seen how PGD can suddenly kick in, making a lung heavy and non-compliant, compromising oxygenation, ventilation, and early recovery. Now, PGD doesn't come out of nowhere. It is an accumulation of insults. The first hit is called ischemia, starting at donor cold flush and continuing through storage. The second hit is rewarming ischemia at the time of implantation in the recipient, when the lungs are deflated and are re-exposed to body temperature, but without blood flow. The third hit, the real tipping point, occurs at time of reperfusion. As oxygen-rich blood re-enters the lungs, this triggers ischemia reperfusion injury. You have to imagine this as a complex inflammatory storm of oxidative stress, complement activation, and crosstalk between innate and adaptive immunity. Now, one underexplored phase in this cascade of insults is lung explantation time, which is defined as the interval between cold flush and the moment of immersion of the lungs in cold solution on the back table after pneumonectomy. Now, in abdominal transplantation, in liver and kidney transplantation, it has been shown that prolonged explantation times are associated with adverse outcome. A systematic literature review about lung studies didn't show any information about this matter. So we aim to evaluate whether lung explantation is an independent risk factor for PGD grade 3. And we hypothesized that lungs, they might be more resilient compared to abdominal organs, thanks to their unique capacity of oxygen storage. So we set up a study, a single-center prospective study at University Hospital Leuven over a 7-year period, and we included both dual heart lung as well as lung-only procurements. The primary endpoint was PGD3 within 72 hours. Secondary endpoints included ICU stay, hospital stay, chronic lung allograft dysfunction, as well as survival. Now, we performed both univariable and multivariable logistic regression analysis, accounting for multiple confounders, including procurement type, as well as lung explantation time. Now, in over 482 patients, we included 367 first double lung transplantations in the final analysis. Roughly a third of the donors were DCD. Roughly another third of the donors were dual heart lung procurements. Now, a typical donor was generally in their mid-50s, being ventilated on ICU for 3 days, whereas a typical recipient was a 60-year-old COPD patient who had been listed on the waiting list for about 9 months. Notably, our center employs a rapid procurement technique. which is reflected in our median explantation times of 26 minutes, as is shown in this figure, where you can appreciate the explantation time on the x-axis and the case percentage on the y-axis. Explantation times were slightly longer in the DPD group, which can be explained by the higher number of dual heart lung procurements, which is confirmed when stratifying by procurement type. Dual heart lung cases do take longer. PGD3 occurred in roughly 30% of patients, which is consistent with literature. ICU stay was about a week, hospital stay about a month. Chronic lung allograft dysfunction occurred in around about 18% of patients, and the 3-year survival was 82%. In our analysis, we showed that lung explantation time was not correlated with primary graft dysfunction grade 3 within 72 hours, neither in univariable analysis nor in multivariable logistic regression analysis. This graph here, this plot, shows explantation time on the x-axis and PGD probability on the y-axis. And this, ladies and gentlemen, is the most important slide of my presentation. You can clearly see there is no correlation. Our analysis also showed that lung explantation time does not correlate with transplant outcomes, which you may see on this forest plot from multivariable analysis, with rightward shifts indicating harm from longer explantation times, whereas leftward shifts suggesting benefit. There was just one exception. Shorter explantation times were unexpectedly correlated with an increased risk for chronic lung allograft dysfunction. We do think this might be a type 1 error, though. Now, our study has several limitations. First of all, it is a single-center study. Second, a rapid procurement technique is meant limited variability in lung explantation time. Third, the DCD dual heart lung procurement sample is small with just 8 cases. Now, I would like to conclude by emphasizing that with rapid lung procurement technique, lung explantation time is not an independent risk factor for PGD3. Lung explantation time does not correlate with transplant outcomes. And in the era of DCD heart procurement, more multicentra data are required. I would like to thank you for your attention. I would like to thank the UZ Leuven transplant team. And I would like to thank the donors and their families. So I would be very happy to take your questions.
Thank you very much. We'd like to invite Dr. Irene Bello from Barcelona to discuss the paper.
Hi. Thank you to the organization to consider me for this late session. And congratulations, Dr. Provost, for your amazing presentation. I think that only few lung transplant groups could have a lot of a big sample, a lot of activity, and these amazing results. So congratulations. And I think that sometimes some data could seem that don't have enough importance, but someone has to demonstrate, and it's something that you did with this work. You demonstrate again that the lung is not a liver, it's not a kidney. It's totally different organ with a different physiology, and we have to consider differently. I don't know if you can listen to me correctly.
Yeah, it's very difficult.
Okay, I see that you
But
are
I'm
doing
really
like that.
trying to grasp.
Okay.
I understand that. Yeah.
Okay.
Yeah.
So I have only I have some questions. Okay, and one thing that I'm not sure that I agree with your work. I have a small concern that in the manuscript you write several times that it's not matter that you don't inflate the lungs, that you don't ventilate the lungs while the cardiac surgeons are doing the procurement. It doesn't matter. So you say the first slide that the primary graft dysfunction is a summary of different insults. And the only way that you have to maintain the oxygenation of your organ during the procurement is the ventilation. So I don't agree with this affirmation that you say in the manuscript. But I have another question. You doesn't take account with the rewarming time in the analysis. Why? It's an important factor for primary graft dysfunction. Your group demonstrated.
Thank you for your question. Thank you for replying on this, for evaluating my manuscript. Well, with regard to the procurement technique about ventilation and oxygenation, maybe it did not fully come through to the manuscript. So we always adopt protective ventilation strategies with a PEEP of 5, tidal volumes of 8 milliliters per kilograms, and an FiO2 of 50%, which continues through the cold flush. And then once a pneumonectomy occurs, then of course this is stopped.
Okay.
So we do adopt, when there is a concomitant heart team, this depends on the heart team. Some heart teams allow us to continue ventilation during the cardiectomy. Other heart teams prefer to have perfect exposure, so they don't want us to do that. So this is very dependent of the thoracic teams we work together with. And then for your question.
Yeah, but I think that most of us would be very easier perform a lobectomy with pumping of the heart, but we don't ask to stop the heart. So maybe doing the cardiectomy, it's more difficult, but I think that I don't agree with don't ventilate the lung with this period. That's that. The question is, why don't you take account in the analysis with the warming time?
If I understand correctly, you mean with the warming time during the DCD prior to, or you mean the warm implantation time?
During the implantation.
Well, because this, our study was really about the effects of explantation time, which is defined from cold flush to the immersion. It's not about the implantation in the recipient.
Yeah, I know, but I mean, you take account different factors. I mean, ECMO during implantation, you know, as a possible co-founders of the study. So you don't take account this part.
That's correct. So we account for multiple confounding factors, but we did not account it for the implantation time. What we did, however, do is multiple statistical analysis, univariate, multivariate, different types of multivariate, where we accounted for both TCD versus DBD and the dual heart-lung versus lung-only procurement type. So, but it's true, we should have included this confounder as well, especially as our UZ Leuven team has shown in a previous paper, that this recurring ischemia time is one of the most important factors, is an independent risk factor for PGD3 development.
Yeah.
So thank you, we could take this into account in our final manuscript.
Yeah, and the only thing that the only question is about the manuscript because your presentation was amazing. So, and you don't analyze the warm ischemia time. You analyze only the total ischemia time, and warm ischemia time is something very specific from DCD. So why didn't you analyze that as a factor?
Thank you for this question. So we did indeed not specifically look at this warm ischemia of the DCD donors, but what we did do is account by an interaction model for the type of procurement, so meaning DBD versus DCD. And there we saw that at analysis of PGD3 at 24 hours, 72 hours, and within 72 hours, that there was no effect on from explantation time on PGD3 development.
Excellent. Thank you very much.
Okay, then we move to the last paper, which is the feasibility of segmentectomy for inner lesions, insight from the pathological confirmed tumor location, from Shina Tane from Kobe, Japan. Please, can we have the slides for the last presentation?
Thank you very much for giving me opportunity to talk in this session. I'm Shinya Tane from Kobe, Japan. I'd like to talk about the feasibility of segmentectomy for inner region, insight from the pathologically confirmed tumor location. And there is no disclosure statement in this study. Some recent two randomized controlled trials provide evidence for sublobar resection in non-small cell lung cancer with a tumor diameter 2 centimeters or below. And segmentectomy has gained popularity in the community of thoracic surgeons. But it is not clear whether segmentectomy is also feasible for inner-located tumor. We previously reported that recurrent-free survival did not differ significantly between segmentectomy and lobectomy for inner regions. However, it is difficult to distinguish these intermediate-located tumors. And I just wonder, this is inner regions or outer regions. So to further establish the feasibility of segmentectomy for inner regions, we should broaden our investigation to consider the characteristics of inner regions more precisely. Therefore, the aim of this study is to investigate the nodal upstaging and prognosis of pathologically confirmed inner regions compared with outer regions, and also examine the feasibility of segmentectomy for inner regions. The origin of tumors were classified according to the classical Waters classification. The tumor arising from main bronchus to segmental bronchus was defined as central type. And the tumor arising from bronchioles was defined as intermediate type. And the tumor originated from minute bronchioles to alveoli was defined as peripheral type. And we retrospectively analyzed patients with C-stage 1A non-small cell lung cancer who underwent lobectomy or segmentectomy from November 2007 to December 2022. And the tumor classified as central type and intermediate type was allocated to inner regions. And the tumor classified as peripheral type was allocated to outer regions. And we compare the oncological characteristics and outcomes between inner regions and outer regions. This slide shows the patient characteristics between inner and outer regions. More patients with the inner region were older age, showed lower pulmonary function, more cases with squamous cell carcinoma, large tumor diameter, and higher SV max on PET-CT. And regarding nodal upstaging, inner regions showed a significantly higher incidence of lymph node metastasis compared to outer regions. And regarding the recurrent-free survival and overall survival according to tumor origin, inner regions exhibited significantly lower recurrent-free survival and overall survival than outer regions. When limited to adenocarcinoma, the nodal upstaging shows the same trend, and inner regions exhibited a significantly poorer prognosis than outer regions in adenocarcinoma. However, squamous cell carcinoma yielded the equivalent nodal upstaging between inner and outer regions. And there was no significantly different between the two groups in terms of recurrent-free survival and overall survival. And next, we focused only on the patient with inner regions. To reduce the selection bias, we performed propensity score matching analysis. After propensity score matching analysis based on age, sex, pulmonary function, CEA, tumor diameter, CT ratio, and SUV max on PET-CT, we compare the oncological outcomes between the patient who underwent segmentectomy and lobectomy. And this slide shows a characteristic between the two groups. After propensity score matching analysis, there is no significant difference between the two groups. And regarding the recurrence pattern, there is no local recurrence in both groups. And regional recurrence was observed in 3 patients in segmentectomy and 4 patients in lobectomy. Distant metastasis or combined regional and distant metastasis were observed in 1 patient in segmentectomy and 3 patients in lobectomy, all of which showed no significant difference between the two groups. And this slide shows a comparison of overall survival and recurrent-free survival between the two groups. The difference of RFS and OS between segmentectomy and lobectomy were not significant. And univariate and multivariate analysis for recurrent-free survival in inner region revealed that segmentectomy was not a prognostic factor for RFS in patients with inner regions. The discussion, previous 3 studies reported the comparison between segmentectomy versus lobectomy or inner regions. But these studies, including our reports, is based solely on CT image. So the pathological characteristics and clinical characteristics of inner region should be further evaluated. This study was the first to investigate the feasibility of segmentectomy for inner regions from the perspective of pathologically confirmed tumor origin. In conclusion, while nodal upstaging and poor prognosis should be considered in the case of inner adenocarcinoma, segmentectomy could be an acceptable treatment option compared to lobectomy. Thank you for your attention.
It's my pleasure to invite Dr. David Jones.
Congratulations to Dr. Tan and colleagues on a nicely presented paper. Your study attempts to do 2 things. First, you try to look retrospectively over a 15-year period of time to determine if inner tumors are associated with nodal upstaging and a worse prognosis. Second, you use the same cohort to ascertain if segmentectomy has the same outcomes as lobectomies for these inner tumors. You find that the nodal upstaging and 5-year recurrence-free survival are lower for inner tumors compared to outer lesions. And you also state that despite these differences, inner lobe tumors can be managed with similar outcomes regardless of whether a segmentectomy or a lobectomy is performed. I have 3 questions for you, and I'll ask them one by one. You use a pathologic definition, meaning Walter's classification.
I'm sorry, I can't hear your question. Please.
Sorry. You use a pathologic definition, Walter's classification, to define inner versus outer tumors. As you mentioned, this is a pathologic diagnosis only reported in 1955, 70 years old. I don't commonly get Walter's criteria in my path reports. I don't know if you do either, but the important point is, since it's a post hoc analysis, meaning a pathologic assessment, how does that impact what you would do intraoperatively or even preoperatively?
Because we we always use PET-CT from 2007, and we pathologically, we preoperatively confirm CM0. And in addition, during operation, when the lymph node is suspicious for positive, we always dissect the lymph node and submit it to the frozen dissection. And if the frozen section reveals the lymph node is positive, we always convert it segmentectomy to lobectomy. So we always evaluate the lymph node upstaging preoperatively and intraoperatively.
I think that partially answered the question. My second question is just to your point, any patient who had an N1 node sampled was converted from a planned segmentectomy to a lobectomy. The data on that's pretty sparse, but how many patients were there in that category, and do you think they should actually be included in your study?
Sorry, please say that again.
Would you like me to repeat it?
Yes, please.
So you note that the patients who had N1 sampling at the time of surgery, if it was positive, they converted them from a planned segmentectomy to a lobectomy. There's not a lot of data on that, but you did it. My question to you is how many patients were treated like that, and is it fair to include them in your trial?
And actually, 5 patients who was planned to segmentectomy, but due to their positive lymph node status, so converted to lobectomy, 5 cases. And these cases was included in the lobectomy group.
Last, there's no difference in whether segmentectomy or lobectomy is done for an inner tumor according to your study. So when you get back later this week to Japan, you have an inner tumor, it's node positive. When you test the node, are you going to convert to a lobectomy based on your own data now, or are you going to continue to do a segmentectomy?
I think the segmentectomy is preferable.
Okay, thank you.
Two very
yes,
quick questions.
One question.
So you did 3D reconstructions on all these patients. I think that's an important message we should give the audience. And if you did a 3D reconstruction and the margins weren't acceptable on a segment, you were going to do a lobe initially, correct? So that was planned pre-op.
Yeah, preoperatively.
Okay. So let's make that message clear. And the second one is what about tornadoes? Were you using dye markers at the time for nodules you couldn't feel? Tornadoes or intraoperative pre-op injecting ICG with a single lumen through an ion or navigational bronch. So we don't miss these nodules. That's our biggest concern in the audience. So we want that message. Did you use tornadoes or fiducial markings or ICG? Yes?
Because it's an inner region, so...
Still works in inner lesions. Did you use that in your series or no?
No.
Okay, well I think our message should be we can't miss these, so we have ways to get better. 3D reconstructions, marking them with a fiducial pre-op, tornadoes, ICG markings, and dye, so we don't leave the OR and miss the nodule. That's what we can't do. All right, thanks.
Thank you. Thank you very much. Thank you to all the audience. This concludes this session, and I wait you at 11:15 for the next invited presentation.